Okay, good morning, everyone, and it gives me a great pleasure to start this eNeo program which has been launched by the IAP, and thanks to the whole committee which has given me this opportunity. And with that, few words of congratulating the IAP team. Let me start with the first.
Yeah. Dr. Ashish, just give
Good morning, sir.
1
Good
minute
morning,
to
Dr.
us.
Ashish. Let me
Ashish.
request Dr. Alok Bhandari, sir, please stay here.
Ashish, just a second. Good morning, friends. I am Dr. Alok Bhandari, President of Delhi IAP. And Delhi IAP has taken up this initiative of a continuous academic activities series in which we have started this neonatology course where stalwarts of neonatology from India and even abroad will be involved in the faculty. Dr. Pankaj Garg, renowned neonatologist from Gangaram Hospital, Delhi, and Dr. Ravi Sachan from GTB Hospital, Delhi are our course coordinators and moderators. They have taken a lot of pains to give structure to this 15 weeks of extensive learning for all of us here. Dr. Vipul Jain is our man Friday for all the technical glitches and technical support to the event. Dr. Ajay Kumar Gupta is our Delhi IAP's academic and scientific coordinator for all the scientific activities. And it is my great pleasure to welcome my dear friend, Dr. Vikram Datta, who is currently head of the department neonatology at Kalavati Premier Institution, Kalavati Saran Hospital, Delhi. Dr. Vikram sir, आप muted हैं, and Ajay, do you want to say anything, or we give the mic to Dr. Vikram Datta sir? Hello, Ajay, आप muted हैं. Ajay, आप muted हैं.
Good morning, everyone. Thank you, Dr. Alok Bhandari, sir. Today's speaker will be Dr. Ashish Jain. He is professor and head of the department at Maulana Azad Medical College. And he has a great academician career, his numerous publications. So without wasting much time, I request Dr. Ashish Jain.
एक minute, I also recognize presence of Dr. Lalan Bharti here and would request Dr. Vikram Datta to say a few words about Dr. Ashish Jain and the course.
Thank you so much, Dr. Bhandari. Warm regards to Dr. Pankaj, Dr. Ravi, Dr. Lalan, Dr. Ajay, Dr. Ashish, and all dear friends from IAP and NNF who are participating in this course. I think it is a most time opportune course, that specialized course which is looking at specific aspects concerning the neonatal care is being rolled out in remote, and that too on a very comfortable time of 9 a.m. in the morning on a Sunday. I think most of the general pediatricians, and I would like to reiterate here that I happen to be a MD pediatrics myself, who since then moved into neonatal care. And that is the point I would like to mention, that there are 3 or 4 very important aspects where neonatal care knowledge needs to come to our friends who are practicing pediatrics and then taking care of the newborn subsequently. First is when the newborns are discharged from the neonatal ICU, the point of contact for the family and the care. As you all know, the follow-up care system in the neonatal ICUs of the country is not very well developed, and we are working on that. So the first point of contact for the family is the pediatrician. And this pediatrician is the one who is taking care of this child right till the early adolescent period. So this pediatrician team, which is comprised of our friends from IAP and NNF, I think it's most important that some specialized knowledge regarding the common aspects, the common queries which need to be handled by the parents, recognition of emergency signs, etc. These are some of the very, very important things which the pediatrician needs to know. Apart from that, the pediatrician also needs to understand that the family is going to come to them with queries related to the feeding, the queries related to the vaccination, queries which are specific related to some specific conditions of the neonatal period and early infancy. And I'm sure this course over the course of 15 weeks is going to address all of them adequately. Warm congratulations to Pankaj for taking this forward. And I can see nearly 400 people who have joined this course, and we're looking forward to a very successful, dissemination of knowledge and shared learning. Thank you so much, Pankaj and Dr. Bhandari. Over to you.
Thank you.
Thank you, Vikramji. Dr. Pankaj, please. Dr. Pankaj,
one moment
please,
that
your words.
me and Dr. Ravi will be involved in coordinating this work, this session. So I request all the attendees to post their questions into the question answer session. And I'm sure at the end of the presentation, Dr. Ashish will be very happy to answer all the questions which have been posted. So let it be very interactive experience. We are not here to make you afraid of neonatology. We are here to make you friendly with neonatology. So we may be DM, we may be MD, we may be DCH, we may be MBBS. It's our responsibility to take care of newborns, because all said and done, 2.4 crore babies are born in our country every year. And it is our collective responsibility to take care of all of them. So with these words, and Dr. Ravi, he's also here. So me and Ravi will take care of it. Dr. Ravi, you want to say something?
No, Dr. Pankaj, please go ahead. Please go ahead.
Yeah. So over to Dr. Ashish. Thank you.
Yeah, thank you, sir, and thanks for briefing that. So, it's very interesting that and very necessary to keep this topic as the first topic, because 90% of the newborns which you face will be so-called normal newborn, and we have certain commitments to take care of them. Yes. So if you look at the definitions we have been using since ages, that what is a normal newborn? So it's a definition given by WHO somewhere in 1996. And the same thing has been used till date after so many decades. So just focus on certain things what the WHO says. It says that if the newborn is born by spontaneous onset labor, wherein there's no risk factor, and the neonate should be born by vertex position, should be 37 to 42 weeks of gestation. And after birth, both mother and infant should be in good condition. So that's the definition of a normal newborn. I would like to emphasize the last line. The last line says that the mother and the infant are in a good condition. So we cannot delink the mother from a newborn. So if there's any problem with the mother, it will eventually reflect in the newborn also. So that is one thing which we should remember, that always look at a normal newborn as a dyad, and also investigate and inquire if mother is okay or not. Having said that, when we talk about the care of a normal newborn, so you have I thought of dividing it into three broad categories. One is that the essential newborn care, which every newborn who is born and normal should get, and that consists of the care at birth, which we often call as CAB, the first examination, and the postnatal care. So these are the three domains when a baby, which are essential to be taken care for every newborn. The next is, you do something in anticipation, that you give a clean chit to the newborn, or you preemptively assume that the newborn will later end up with these problems. So you undergo screening of newborn, which is important nowadays. And a lot of domains now come under universal screening. That is, you screen all the newborns. You give a proper advice as to when to follow up and what are the pre-discharge advice. And obviously, the immunization is a very important part of newborn care. And then when these newborns come for follow-up, I'll tell you what is A, B, C, D, E, F, G. So I've just devised this simple mnemonic so that you can remember in your clinics that what to see in a newborn when he comes for a follow-up visit. So that's our schemata on which we will be discussing the things about care of normal newborn. If you look at the objectives of newborn care, there are four main objectives, or you can call it the four main pillars of newborn care. One is that he should be breathing normally when he is born. Second, he should be feeding normally. That is, his nutrition should be taken care of. And if you look at the thermal care, which is very important, because a lot of things will actually become bad if you don't take care of the thermal care. And then finally, all through the journey, he needs to be protected from infection. Having said that, one thing is very important at the bottom line, that we should not do any harm, and we should go with the physiology and avoid overindulging or overdoing things. That is also very important, because we are talking about a normal newborn who otherwise doesn't need any care. So when these four domains were thought of, which were essential for the newborn care, then we look at the interventions which generally are done to take care of these four requirements of the newborn. The first intervention is to initiate breathing and resuscitation. The second intervention is for exclusive and early breastfeeding. and the third is the thermal protection, and then the clean childbirth and cord care. So these are the core interventions which have to be focused when a pediatrician attends a delivery and takes care of a normal newborn. So at what stages do you take care of these four interventions? So there are three stages. One is, the preparation before the delivery, so that journey is very comfortable for the normal newborn. Second is immediately as the newborn is born. And third is essential postnatal care after the newborn is born. So let's take up the first one, that is preparation before the delivery. So if you look at the preparation before the delivery, I would like to, take you back to the first slide, which said that if the mother is not okay, then eventually the newborn also will not be okay. So it's our duty to, abreast with the mother, talk to her, counsel her, ask her for any problems, maintain her privacy, and also, make her comfortable before the newborn is born. The second domain is to get oneself prepared so that you don't give any infection to the newborn. Wash your hands, gown down, and receive the newborn, and then do a checklist as far as the resuscitation is concerned. We'll not go into the detail of the checklist because you will have another talk on that coming maybe next week. So that's the important things what you have to do before the newborn is born. And then it's always important to remember that there are these 6 cleans so that no infection seeps into the newborn. Washing the hands, cleaning the perineum, placing the mother on a clean surface, using a sterile device to cut the cord, clean the cord, and cord care. So these are some of the important 6 cleans which are being rolled out by the ministry, and they stand very effective as an intervention to prevent infection when the newborn is born. If you look at the second area where you need to implement these interventions, that is immediate care at birth. So as soon as the newborn is born, we are now talking about normal newborn. So a normal newborn would actually have a good tone, is generally a term newborn, will be breathing and crying. So when you receive such a newborn who is apparently normal, so what he needs is only the routine care. So he doesn't go to the algorithm of an RP. He just needs routine care. So what does this routine care mean? That we have to receive the newborn in a dry cloth, dry him, place him on the lower abdomen of the mother, wait for a minute to clamp the cord. After that, you clamp the cord, cut the cord, move the newborn between the breasts of the mother, and initiate the breastfeeding as soon as possible. So this is all what is routine care. So in the pictorial, you can see a mother who is just given birth to a term newborn, and the newborn is between the breast of the mother, and within few minutes, the newborn will be navigating himself to the nipple, what we call as a breast crawl, and will start breastfeeding. So that is how the care of a newborn should be done, who is normal at birth, by giving him routine care and skin-to-skin contact. And that will maintain his temperature also in the normal range. So to summarize, what you do at birth is you receive the newborn in a warm delivery room. As soon as the newborn is born, immediately dry the newborn. And then, as we discussed, put the newborn on a routine care with skin-to-skin contact. After that, initiate the early breastfeeding as soon as possible. Postpone the weight of the bathing of the newborn, because this is the time when the newborn may go hypothermic because of these interventions. So avoid this. Even the WHO says that any weight taken in the first 24 hours can be considered as a birth weight. So there's no hurry to put this newborn on a weighing machine, naked newborn on a weighing machine, and put him at risk of hypothermia. So you can delay this, and then after that, put him on a appropriate clothing, and the newborn now stays with the mother from that point onwards, maintaining a warm chair till the mother goes to any area of your care. It may be a monitoring area or a postnatal area. So we say that from this point onwards, there should be zero separation as far as the baby and the mother is concerned. So this is what you take care of a newborn, normal newborn when he's born. There are a couple of other, care which are important apart from this schemata. The first is, the cord care. So how do you take care of the cord? You clamp and cut the cord with a sterile instrument, as I already discussed. Tie the cord between 2 to 3 centimeters from the base More important that this dangling cord should not be touching the genitalia. So I think more than the exact centimeters, you should take care that it's not going till the genitalia. Observe for any oozing of the blood. Do not apply anything on the stump and do not bind or bandage the stump. So it's just kept the way here. So you apply a clamp and it is kept dry and the stump is kept uncovered. So a practical tip is that when you put diapers on these newborns, so these diapers should not go up to the umbilicus because that is harmful for the baby. So it should be something like this, which is shown in the pictorial. The other three important immunizations, rather I would say two important immunizations, and the BCG can be given before discharge. The two which generally we give at the birthing place are the hepatitis B and the oral polio. So these are very important immunizations at birth which the newborn should require. Apart from this, all the newborns should get vitamin K prophylaxis. So I would suggest you to read these very crisp operational guidelines which are released by the ministry. They are freely downloadable for vitamin K prophylaxis in birth in all facilities. So who receive this vitamin K? All the newborns delivered in facilities, let it be public or private, they should receive the vitamin K injection. The vitamin K1, that is a phytoquinone, should be used in a dose of 1 milligram per ml or 1 milligram 0.5 ml, preferable to stock 1 milligram per 0.5 ml because the dosage is less. What dose do you give? You give around, for the birth weight of less than 1 kg, you give around 0.5 milligram, and for birth weight more than 1 kg, you give around 1 milligram. What's the site? It's like an anterolateral aspect of the thigh in the intramuscular injection. Anyone can give it, a medical officer, staff, nurse, or ANM, and it should be given, in the labor room, or it may be given in the postnatal ward. Try to remember that to give the vitamin K injection once the baby had already started breastfeeding, because sometimes it is a stress and it will affect your initial start of breastfeed. So there is no hurry. Maybe once the baby has a couple of breastfeeds, then you can give vitamin K. And the logistics is you need a 26 gauge needle, 1 ml syringe, and then you give this injection to the baby. So that is another important intervention which should be done at birth. The other one which the people do is the prophylaxis for conjunctivitis. But in India, we have seen that most of these antibiotics are not used by us because the incidence is very less. So best in an Indian context is that you use plain cotton swabs in normal saline and try to clean the eyes from the medial side to the from the lateral side to the medial side. So that is how you just clean the eyes, and that itself will take care of prevention of neonatal ophthalmic neonatal. So having talked about the care at birth, let's come to the next, that is the first examination of the newborn. So as a pediatrician, when you receive a newborn, you should go through a crisp, vital examination of a newborn, which is as important as taking care of a newborn. So what do you do in this first examination, and why this examination is important? Because this examination is important because you are actually confirming a smooth cardiorespiratory transition of this newborn after he's born. You're looking at any special need the newborn requires so that you can redirect his care to that particular special need. And the third important objective here is to screen all visible defects at least in the newborn. So these are the three important objectives of having the first examination. So this is a schemata which shows you, what all to examine to rule out the visible birth defects. Let's start from the eyes. So see for the cataract, look for the red reflex, look at the head and the face for frontanale, facial appearance, dysmorphic features, and look for the chest if there are any retractions, if there are any heart sound, murmurs. Look for the femoral pulses. Look for the abdomen for any masses, enlarged liver, spleen, kidney. Look for the upper limb for digits, palmar creases, maybe mouth, very important. Open the mouth and look for cleft lip, cleft palate. Is there any central cyanosis which is persisting? Look for the hips, for the dysplasia of the hips, and then the lower limbs for any talipus, positional equinovarus, genitals for hypospadiasis, undescended testis, ambiguous genitalia, anal position, ectopic anus, and then turn the baby and examine the whole spine for any midline defects. So you have to go through this quick examination of all parts of a baby. And apart from this, also generally see what's the weight, length, and circumference of the baby, how is the baby overall moving, how is the tone of the baby. Apart from the skin, that is the baby very plethoric? Does he look pallorish? So these all things should be looked at the baby as a first examination. So the sequence of the examination, if you see, when you're doing the first examination, should be the first should be your general observation that whether the baby looks ill, lethargic, whether the cry is abnormal, color of the skin, as I showed you in the last schemata. The second is you look for the head and the spine. The second thing what you look is for the head and the spine, where you look at the circumference, look at the cap, look at swelling, protrusion. Third is you come to the face and the eyes, ears, and mouth. So these four things should be looked at as the next sequence, wherein you're looking at any dysmorphic facies or asymmetry in the facies when he's crying. Look at his eyes, swelling, droopy gap, eyeballs, ears, absent abnormal shape of low set, mouth, cleft, split, left, and palate. Then you come to the chest, look for the shape of the chest, look for the distended abdomen, wall defect, gaps, and anus. Then come to the genitalia, look for the various abnormalities of the genitalia. Keep a point on the urinary tract also. In fact, this examination goes later on also, where you look at whether he's passing urine appropriately, whether there's a lower abdominal swelling or not, and then look at the limbs. Look at the limbs for the major disabilities, look for the minor disabilities, the number of digits, extra digits, club foot, and all this should be ruled out. And finally, maybe some markers for the chromosomal abnormalities. So that should be your sequence when you're examining the newborn on the first go. So you have this chart for visible birth defects, which is available from the ministry. It can be downloaded by anyone. So you can download such a chart and prepare one of the charts and keep it at your birthing places, so that anyone who is attending the delivery can actually go through these different areas of a newborn and rule out whether there is any visible birth defect. So it's a beautiful chart which has the figures as well as the very common birth defects which are present and sometimes missed. So you can look at this chart. Also would guide you to, would suggest you to go to this comprehensive newborn screening, a screening handbook for the birth defects at delivery. Again, a very good ministry RBSK, booklet, which will also give you a paper which you can use and attach to the case sheet, so that you can confirm that you look for the visible birth defect. So you can just take a photocopy of this case sheet and do it for every normal baby, wherein you don't miss anything, and it gives objectivity as a checklist that you have checked for most of the birth defects. The next important thing is to monitor the baby. So this baby is just born, and if it looks okay at born, you should not just leave the baby alone especially in the first hour or two of birth. Monitor the parameters of this baby every 15 to 20 minutes. Look that he's not going into grunting, chest indrawing, fast breathing. Take care of the warmth of the baby and evaluate the color and trunk of extremities. So these three things are very important for the first couple of hours when the baby is there with the mother. So we need not do anything aggressive, but we have to confirm that the transition has occurred normally and the baby is not facing any problem. Coming to the last domain of the essential newborn care, that is the postnatal care. So that is when the baby has moved with the mother to the postnatal ward or has already spent 2 hours of your observation period, then what do you do? So generally when you go to see the baby, bedside when the baby is with the mother, so you assess the baby, and the assessment of the baby here is not just touching the baby and looking at the baby. Ask the mother, look for certain signs, listen patiently to what mother is telling, what are her concerns, and then feel the baby. You classify it based on these four, important inputs, whether the normal signs are there in the baby, or he needs additional monitoring, or there are certain danger signs, and treat if any of these things are there. So what is very important here is that you should listen to the mother, who is a very astute examiner, who has been with the baby when you were not there, and then try to counsel her about the normal physiology. So the dictum is that let it be a pediatrician or neonatologist. He is always graded down than the mother, who is a very astute examiner, and she would actually many times tell you about the problems of the baby. So any problem which is delivered by the mother, kindly don't ignore it and take it seriously. So what should you ask? You should ask about breastfeeding, whether the baby is breastfeeding well. And if the mother tells that he's feeding well, then don't unnecessarily, give her advice about position, attachment. That all is useless. If he's breastfeeding well, that is done. Whatever the dyad is, managing and feeding well, then don't interfere with it. Look at the respiratory pattern. Look at the vomiting, stooling, urine, sleep and activity, and if there are any maternal issues. So these are the important things which you should ask in the postnatal ward. What you will be asked or what you listen from the mother very often is that there is less milk, what should I do? So it's very important, look at the physiology. If the urine output is okay, the sleep is okay, weight pattern is okay, then just counsel the mother. She may tell you that is not passing stools or more stools. So again, we should know about the physiology that the baby may sometimes not pass stool till 2 to 3 days of life. So just look at the anal opening and re-examine the genital area and then explain the physiology to the mother. Many mothers have a complaint that the baby sleeps often. So kindly examine the baby, check the activity and the vitals. If they are okay, then again you have to counsel the mother that the babies generally sleep around 16 to 18 hours a day. Should I bathe? What should I do? So that's another question that the mother will ask. So generally we do not recommend any, shoulder baths in the hospital or till the fall of the stump. So even though there's no evidence favoring or not favoring this, but that is the general advice. So whatever advice you give, let it be uniform, given by the whole of your team. The best thing is to avoid the shoulder baths. Just do sponging when the baby is in the hospital, and at home when he goes and the stump is fallen, then you can advise the mother to give shoulder baths, not the baths from the head. Powder is absolutely no. It is proven beyond doubt. So the powder should be discouraged. Oil application can be applied, but you should know what the content of the oil what you're applying, and it should be pure oil. For example, not to mention the commercial products, but I'm just giving an example. A parachute versus Vatica. So you'll have some more things in Vatica, but that is not needed for the baby. So you just give him some pure coconut oil. That's good enough, and it should be a clean application, and massages, especially in low birth weight baby, should be avoided. So you can apply the oil. And then the breastfeeding issues, if at all they are there, go back and examine the attachment and positioning of the mother. So that will take care of the breastfeeding issue. So these are some common things which you listen from the mother and some common advices which you should give. Carry at least a thermometer, have a weighing scale around, stethoscope, and obviously the clean sheet should be there. The baby and mother should be together when you're examining, and the room should be warm. So these are certain environmental issues which you should take care when you're examining the baby. And then, as I said, look at the movement of the baby, posture, pustules, color, umbilicus. So these are all other things which you should maybe degloat the baby and look at them once more when you examine the baby. So as far as the weight loss is concerned, we all know that they may lose up to 5 to 7% in the first 3 to 5 days, but then quickly they will regain by 10 days. So keep that physiology in mind and accordingly take the action. Generally, they gain up to 1% of the body weight per day in the first month. So that is how you can counsel the mother that the weight will go in this pattern. If she knows the pattern, then the worry will be less, the breastfeeding will be okay, and eventually it's a vicious cycle. If she doesn't know what happens to the weight, then she'll get worried and the weight will further be affected. So this thing should be kept in mind. So after having done that essential newborn care, let's come to the next part, that is the care in anticipation. So now we want to actually look at certain things which maybe our abilities, our clinical acumen cannot pick up. And that's why we do a screening of these babies. And if you look at the screenings, the 5 major screenings are the pulse oximeter screening, the red eye reflex for the eye, the hearing screening, and the dried blood spot for the commonly occurring treatable causes, and the visible birth defect we already discussed. So if you look at the hearing screening, any personnel with basic knowledge of computer and good communication can actually do a hearing screening. So we use the OAE as a first screening methodology between 24 to 48 hours of birth. Sometimes the babies fail on this just because of certain amniotic fluid in the station in the auditory tube. So you may repeat after again you can repeat after a couple of hours once this thing is cleared. So if the OA is passed and there are no risk factors or NICU admission in a baby, as we are talking about normal baby, then you just give information about hearing milestones to the parents and do a routine follow-up. But in case you have a refer there, then you repeat at the first immunization visit at 6 weeks. And even if that is refer, then you need to get a proper diagnostic ABR done within 3 months. Now we have become more aggressive. So it is to be done, soon, immediately. And then if it is normal, then again you go to this pathway where you give the mothers important, information about the hearing milestones. And if it is abnormal, then you undergo a detailed diagnosis and the remedial measure should be started by maximum 3 months of age. So that is how you do a universal screening for all the babies who are born. The next is the pulse oximetry screening. So you take a pulse oximetry at the preductal and the postductal. Obviously, the preductal will be the right upper limb, postductal will be any one of the lower limbs. And generally, the pass, to say pass, the pulse oximetry should be more than 95%, and the difference should be less than 3% between the upper limb and the lower limb. If that doesn't occur, which is the fail, then you repeat the pulse oximetry after 1 hour. Still, if the baby fails, then maybe some protocols would say to repeat again after 1 hour. But if it fails later, then he goes for a diagnostic evaluation and clinical assessment by doing a echocardiography and a detailed clinical assessment. So on clinical assessment, if you find no other cause, for example, pulmonary cause for this particular variation, then it's very important to detect the critical congenital heart disease immediately and get the baby screened for echocardiography. The next is the dried blood spot. So it's very easy. So generally done at 48 hours to 72 hours. So it can be done by a simple heel prick, then take a drop. There are a lot of documents telling that how appropriately you should take the drop, and then depending upon the 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 babies you are getting, so you can basically decide your panel of what you have to screen. So that is how, but generally the screening is done, should be done universally for at least the congenital hypothyroidism. Then you look at the red reflex in the children. So you use a direct ophthalmoscopy, can use an ophthalmoscope, set that ophthalmoscopic setting to +2, that is the green or the black, and then focus on the patient's eyes. If you see this thing where both are red, so that is a normal red reflex. And if you see like that, there is obvious asymmetry and urgent referral is needed. And then the red reflex is abnormal, then you need an urgent referral. So this is all important, another important screening. Apart from this, now as we have identified the delays, so there are two more screenings I would like to introduce. One is the stool screening of the stool. So you can use this stool card, which is again developed by the Infant Stool Card Registry. So that tells you about the normal stools, which are the lower ones, and the abnormal stools, which are the upper ones. And that will again give an idea about the antecedent cholestatic jaundice. The second is the screening of the jaundice. So the units who have actually the transcutaneous bilirubinometers, now the WHO recommends that before the baby is discharged, the baby should undergo a screening at least by the TCB, and he should be put on a chart which predicts whether this baby will have jaundice or not, and then you can call him accordingly on the follow-up. So apart from these 4 screens, what I discussed, maybe these 3 screens are, and the 2 screens are another important screens which are developed over time, and now more and more units are doing it. After you've done the screens, then what is important is the pre-discharge advice. So now you're taken care of a baby at birth, you've done your first examination, you have done your routine postnatal care of a baby, you have done screenings of a baby, and now you actually are advising the mother that when to come back and what important advice is needed to take care of this normal baby. So I've just put certain important advices here. So first is you congratulate the mother first, have a rapport with her, and tell her that breastfeeding and zero separation still stands good, and the same things you should do in the home. So before discharge, again examine the cord and tell her about the cord care, because a lot of myths and a lot of practices which are present. So you have to bring out this topic and discuss with the mother. Explain her about the danger signs, which may be lethargy, hypothermia, maybe RD, cyanosis, convulsions, distension, seizures, and reconfirm that she has understood that how to identify these danger signs. Tell her about certain innocuous findings, maybe a Mongolian spot, maybe Epstein pearl. So these important findings which are present in her baby, don't just narrate a whole list. So if some of these findings are present in her baby, try to tell her that these are innocuous findings, and she have to just do nothing about these findings, and they'll be okay. Tell her about the skin care and the bathing. We already discussed about that, and something about the eye care, about the kajal application and cleaning of the eyes, and epiphora, which is very common, the nasal blockage. You can just tell her to massage, and that helps. So these are certain, certain tips which you can give to the mother. Then you immunize the baby. So on the visits, and I think I'll not go into the detail of immunization, but I just wanted to put this chart that a lot of immunizations now, which were in the optional, have already come to the government system also. So wherever you're following up the baby, the best interest of the baby, you can follow the IAP chart or the universal immunization chart and try to immunize the baby at the particular period, at the particular dose, at a particular site, and then take care of the post-immunization issues. After that comes the follow-up visits. I just want to ask that am I out of time, or I can take some 2-3 minutes more?
So take your time, you're comfortably as much as you want.
Go ahead, Ashish.
So then we have the follow-up visits. So sometimes you have a thought block among residents, among the new private practitioners, that what do I see at follow-up? So I've devised this very simple formula: A, B, C, D, E, F, and G. Maybe it interests you and it helps you to remember what to look at the child. So before we actually call the child for the follow-up, more important is that what are we writing and how are we discharging the child? So when we discharge these neonates, whatever schemata of discharge you're using, some of the components are very important in that. So one component is the complete address and telephone number, the discharge summary, the referrals or the logistics, whatever were there, which are left out. Mainly it is about the screening. Then some parental education, maybe on the backside of the discharge. And very important is that give them clarity about if something happens, what's the emergency number, where do they come, how do they approach. So these all things should be there as a key components of the discharge. So this schemata we follow for the high risk. Slightly I have altered for the normal baby, and we'll go through this normal. So first A is that when a baby comes for the follow-up, look at his anthropometry. So what are we looking at anthropometry? We are recording his weight, and the weight should be recorded always without clothes and diapers. The scale may be 10 gram at least sensitive. Long back we used to use 50 grams, but now most of us are using 10 grams because there will be some normal LBW babies also coming to you. And then inflant is placed at the center of the pan, distribute the weight evenly. Weight should be monitored in each visit. So that is one thing we should do in each visit, is to monitor weight. And then you should know that how this increment occurs. As I said, that it's generally 14 to 20 grams per day after 10 days in term and 20 days in preterm baby. So around approximately 0.75 to 1% of weight per day, the baby has an increment. And what charts do you use? So we generally use the WHO charts for the normal baby. And if they are born like near term later, if the preterm babies are, then we can use the intergrowth preterm follow-up charts. But for the term baby, normal babies, we are using the WHO growth charts, and these growth charts are there for all. They are there for the weight, they are there for the head, and they are there for the length. So the head circumference, the length, and the weight of a baby all should be plotted on these WHO MGRS charts. I'm not putting all the charts. I'm just giving you a look into how these charts look. So there are three types of charts which you have to use: one for the length, one for the head circumference, and one for the weight. And then you have the pink ones which are for the girls, and the blue ones which are for the boys. The next is, after the A, we have finished with the anthropometry. The next is the breastfeeding and feeding. So now the next important issue is the feeding. How is the baby feeding? So this is a time to talk to the mother about breastfeeding. Ask her, just if you are fortunate, you can just examine a breastfeeding session, see that the attachment positioning is okay, see that she's not feeding anything else apart from the breastfeeding, number of times she's feeding in the night, because that really helps to increase the milk output, and also ensure that there is an adequate delivery of milk and handling. So many times we find babies who are excessively crying. So one should remember that if the mother alternates the breast very often, then the baby eventually gets the milk. And the milk, as we all know, that is 87% water, certain minerals, and very less of calories. So tell the mother that she should put the baby on breast, try to empty one breast and then go to the next breast. So once the baby gets the fat in the hind milk, he will be satiated and the cry will be less. So this is a very common advice and intervention we do whenever a baby comes with excessive crying. Also tell her about the breast hygiene, the breastfeeding problems if there are any, then try to sort out those problems. And I will talk about the supplements, that what supplements we give to the baby. So these are the common problems that the mother may come with. She may come with engorgement, blocked duct, mastitis, breast abscess. They are very simple advices and interventions which are available, with picture and videos on the net, so you can look at them, and solve the issues. So when you come to the supplementation of the baby, I've just put LBW and ABW. So that is babies who are low birth weight and babies who are appropriate birth weight. So maybe we are dealing with both these babies when you're talking about the normal babies. So they need only two supplements. One is the vitamin D, which can be started as early as possible and then go infancy and beyond at 400 IU per ml. That is the iron. So in the LBW babies, we start iron at around 4 months because of limited accretion. But if you see in a in a baby who is more than 2.5 kgs, you can start at 6 months. But then again, if your complementary feeding is very good, you may also go away with iron. You don't need iron at all. But that's more a ideal situation. So most of the places you need some iron supplementation. So the vitamin D again should be started as early as possible and continue for infancy and beyond, generally 18 months. Give at vitamin D 400 IU per ml. And iron, if there is some issues with the complementary feeding, the normal babies can be started iron at around 6 months of age. And if you're very okay with the complementary feeding methodology and the iron intake, this thing can also be avoided and the baby can just be on vitamin D. This is the complementary feeding chart. So many times the mothers will ask, what food do I give? How much quantity do I give? What is the frequency? How many snacks do I give? So this is again a very good chart which is prepared by the IVCF team, and one can use this chart, have it displayed in your clinic, and then the mothers can use this. You can use this chart to actually advise the mothers about the quantity, the content, the consistency, and the frequency of feeding. So that's a very important handy chart. After we have finished the B, that is the breastfeeding, feeding, and supplements, all that come in the B, we come to C. So C is the most important. Unless you address the concerns of mother, you will never have a good rapport with the mother. The mother will never open up with the problems. And as I said, the mother is, by a dictum, the mother is a keen observer. She has been with the baby all the time. So her, problems are, very pivotal to understand. So we already discussed about this. General concerns of the mother will be the eye care, the oil massage, the powder. So I already told about this. I'll not waste time on this. Also the bathing, the daily bath is not required. Alkaline soaps, they increase the pH of the skin and interfere with the function. So try to use a soap which doesn't have any alkalinity. Shoulder bath is to be given in the home environment only after falling of the cord. Sponging may be done when the neonate is in the hospital environment. Soap is never used in the newborn's face. Infant should be immediately dried after bath. And traditional, practices which are good should be retained. Otherwise, anything putting oil in the ear, nose, boric acid, kajal, surma, they should be discouraged. So these are some of the advices or the concerns of mother you should address. Then comes the developmental screening. So after we have taken care of anthropometry, we have taken care of breastfeeding, feeding, supplements, we have talked to the mother, know her concerns, advised her, then comes whether the baby is developing normally or not. So this is a development screening. So the best thing to do is, not to pick and choose one own milestones. Try to use one of the screening, charts which are present. So there are standardized developmental screening which should be done at 3, 6, 9, and 18 and 24 months. And it will not make you make a diagnosis, but at least will give you a know about the baby, whether he should be referred to a developmental pediatrician or not. So the developmental screening, basically there are three things you can use. You can use a Trivender developmental screening chart, which has 17 items, 0 to 2 years, with a sensitivity of 66.7 to 78.8%. You can use a Denver developmental chart, the variation 2, or the Baroda developmental screening test. So we are using the Denver developmental screening test, which is a very simple screening test. So it tells you about the domainal development of gross motor, fine motor, socioadaptive, and language. It can be used from 0 to 6 years as 123 items. Not that you have to do all the 123 items. You have to just do 3 items on one domain. So it just finishes in around 10 minutes. Mainly you have to do around 9 to 10 items which are there. So these 123 items is the whole lot of the items in the chart. But when a baby comes, what you do is you draw a line like that. Suppose he comes at 2 months, you draw a line at 2 months, and then the blue ones are the milestones which are completely onto the left, the baby should pass. So that is our intention. There is a way how to score this developmental screening chart, so that I will not go into the detail, but nevertheless to say it is very simple to understand, simple to apply. So maybe there would be a session on developmental follow-up of the babies where we can spend some more time on how to do the developmental screening chart. But this is a simple chart. And even if you don't want to use the chart, the developmental Denver also gives you an app for very little money, which you can just put into the milestones and it will give you whether the baby is, suspect or it is normal. So this can be done as a routine. After that, you see for the emergency signs. So many times, the mothers come with some problem, and these problems are undermined or estimated by the mothers, and they would be some hidden emergency signs. To try to look at the emergency signs. So some of the emergency signs which may be possible that the mother may come in a post-natal visit to your clinic would be, whether he's not feeding and lethargic. So the mother perceives that he's not feeding, but actually the baby is very lethargic. So try to identify this important emergency sign. Respiratory distress, grunting, again may be undermined by the mother. So try to identify this sign. Neurologically, if he has seizures, convulsions, jaundice, if the palms and soles are yellow, if the baby has fever or hypothermia and undetected malformations. These are some of the emergency signs which you should look at when the baby comes to the clinic. After that, there are some fuzzy childs. We all know that these fuzzy childs, they come to you. What is this fuzziness? So excessive crying and what to do and what not to do. I just bought this slide because I think this is a very common problem that the baby is excessively crying. So what's important for rearing of a baby, to avoid these problems is that you apply regularity and uniformity in daily care, allay the parental anxiety, assess the environmental factor, the social and domestic context, rocking, cuddling, soothing, and sometimes the phenyl extract or may help, the Dana oil or the phenyl extract, which generally give for the colicky and all that. What you should avoid is discourage any change in feeds, and if there's any no evidence of lactose intolerance, don't try to actually brand that as excessive crying, and no probiotics as such are necessary routinely. The colics is generally overrated, overdiagnosed, and generally if the colic is not handled by the parents, and you should always think of certain pathology and try to investigate the baby for pneumonia, meningitis, or ICH. So don't forget that the colics which are really troublesome, they need certain workup to rule out certain things. There may be certain variants of newborn behavior again in these fussy childs. There may be some childs are just excessively crying and nothing is found on investigation. excessive sleepiness may be there. There will be lack of diurnal sleep and gastrocolic reflex. They all are, extremes of normality. So some things you can try is, challenging the challenging period for parents, and it's very significant exhaustion for the caregivers. So many times there's a lot of counseling for the parents which is needed for this altered behavior rather than the newborn. So try to spend time with both the parents, the mother and the father, to take care of these, issues. And the last part is giving assurance. So before the baby is departing, so you give assurance about certain things. Assurance about the seasonal and viral illnesses. So they will always be there. So the baby can't be perfectly, non-choresic and, so that you have to give suboptimal growth. If it is there, that's okay. But then if the danger signs are not there, you can still follow. Skin conditions and variants in neuronal behavior, we already discussed. Certain developmental variants, maybe physiological bowing of the legs, some amount of metatarsals. So those all things also you should be able to, advise. And minor malformations, if at all they require any elective interventions. So some things which you commonly face is the nasal blockade, noisy breathing, and normal respiratory. If the respiratory examination is normal, they just need a symptomatic management, parental counseling, and preventive precautions. So having said that, I'll come to my last slide, which says that, in most of the times, a normal newborn do not need any care and should be left alone. You need to only guide, do not overindulge with the physiology. The more you dig and search, the more you'll intervene unwarrantedly. So, there's a gray line between, how much do you investigate, how much do you go into the normal newborn care. So that's one thing you should always remember, that there's a lot of physiology occurring here, and we should first understand the physiology. Thanks a lot, and thanks again for the IIP team to give me this opportunity.
Thank you, Dr. Ashish. So you taking care of a normal newborn is a very tricky job, because as you said in the first beginning of your slide, WHO has defined normal newborn as one delivered vaginally, vertex, natural conception. And as you can see nowadays, LSC is going up, IVF, other modes of delivery, that we are getting lesser actual definition of normal newborn. But what we wanted to say is any baby who does not require intensive care and goes to the mother directly will be a normal newborn for the larger perspective of normal newborn care, which you all very correctly delineated in your presentation. There's a lot of enthusiasm generated in the audience, and there are 37 questions. And I want the questions to be answered directly. So I will quickly go on to the questions as early as possible. So first question is by Dr. Ranjan Kumar Mahanta is how to examine eye of newborn, because as it is challenging, they don't open eyes. And I have seen my residents pulling apart the eyelids to examine the eyes. What would be the right position, right way of examining eye of a newborn?
So we need to exploit the labyrinthine mechanism. So hold the newborn in your hand, and just aarti karte hain, you just try to rotate and the newborn will open the eyes. So
Right.
that's the easiest way to open the eyes. So just hold the newborn on the head on your palm and try to just rotate slowly, and he will open the eyes. So
There's a connected question to this, that we also said that the red eye reflux has to be examined to
yeah.
look out for cataract or any corneal opacity. So what will be the right time to examine the red reflux? Is it at birth, in the 24 hours, or before discharge?
Yeah, because this doesn't change over time. So the earlier it is, the better it is. Because if you identify certain problem, we are committed to communicate it to the parents as early as possible. So I would suggest that if possible, it should be done after birth immediately as a first examination. The other things can wait, because that's very vital.
Because usually babies are able to open eyes better at birth, and at that time you have more time. Actually, once the baby is with the parents, it is really difficult to make the baby rock and make the baby open eyes and do the ophthalmoscope examination. So birth will be a better time, but yes, it has to be done. That is most important. So next question by Dr. Prashant is that BCG, hepatitis B, polio is given to all newborns, only to healthy ones, those excluding in NICU, or all newborns?
So the intent is to give to all newborns, because this talk was related to care of a normal newborn. So we just discussed that the normal newborn, they should be given, but not that the sick newborn should not be given. They also get the immunization.
So we know that in NICU, normally we trying to avoid the live vaccines like OPV. So we may give it at the time of discharge, but maybe those very preterms who are going to stay with NICU long period of time, we avoid that. And maybe at the time of discharge, all the vaccinations now, it's clear with hepatitis B also, it can be given at discharge, BCG, polio, everything can be given as discharge.
So
But
we are looking at a process system where the baby is handled, at one particular point. So at birth, there is always a pediatrician. So I think that is a time when we should finish this. Not a lot of evidence for live vaccines to be avoided in nursery, but then yes, doesn't matter at discharge also you can give.
No, I'm saying for preterm babies, those who are in the
Uh,
NICU, maybe at that time your priorities are different. Your
Yes.
priorities are sickness, the respiratory support,
So
other things.
there your immunizations come in a discharge checklist where you have
Right,
to do
right.
that for discharge.
So Dr. Meet Patel wants to ask what are the associated
Dr.
abnormalities?
Ashish,
Yeah, yeah,
Dr.
Dr.
Pankaj,
Pankaj.
Dr. Pankaj,
Please, please.
just related to just related, there are because there are few queries on these vaccinations. So just adding to your questions, Dr. Ashish, there is two or three questions regarding the gestational age and in the weight criteria about the hepatitis B and vitamin K injection.
Yeah.
Please throw some lights.
Yeah. So we'll take up the first, the hepatitis B. So if you look at the Red Book and the Western guidelines, there is a certain weight criteria beyond which you should give the hepatitis B. But there are studies from your own institution, UCMS itself, which has shown diligently that it doesn't matter with the weight. So any weight, the hepatitis B vaccine can be given. But then definitely it can be delayed till discharge. So that is one thing. But when you are talking about the normal newborns, absolutely there's no contraindication to give hepatitis B. As far as the vitamin K is concerned, I already put that slide that if you are facing a baby who is less than 1 kg, then 0.5 is the dose. And if you are facing a baby who is more than 1 kg, then 1 milligram is the dose. And that is the phytoquinone you give IM with a 26G needle.
There's a connected question to vitamin K that if somehow it has been missed at birth, till what time it can be given?
Okay. So when we give vitamin K, so generally we are trying to prevent the classical VKDD, that is vitamin K deficiency disease, which generally comes between 3 to 7 days. So that's the time when the VKDD comes. Anyhow, will not be able to prevent the early VKDD. So if you delay it beyond 3 days, then you may end up with manifest of VKDD classical. And it is seen that the vitamin K injection, once you give, it takes around 8 to 12 hours to kick off the coagulation factors. So I would suggest that it should be given within 48 hours of life.
And a logistic solution is that we have mandated in our hospital to write the date, time, batch number, and expiry date of the vitamin K. So just you can't just tick it and go away. It has to be really documented so that nobody can complain that it was not given or it was missed. So it has to be documented properly because many times we get the baby referred to us from outside and it's very difficult to ascertain whether it was really given or not given.
That's a process to actually confirm that it's been given and communicate this confirmation in some form of badge to the parents. So that's a good idea.
Dr. Meet Patel wants to ask associated abnormalities with extra digits, both feet, like 6 feet or what, polydactyly.
Okay. So, there are a lot of anomalies you associated, but I mean, the genetist would be better, able to tell you. But what I would suggest is there are multiple. So, what you'll face babies with all 4 limbs polydactyly. And with that, if you have the length of the baby which is less, then the Elvis Van Creveld is one of the things you should be looking at. A single digit, which is post-axial, may not be associated with many anomalies. But if you have pre-axial extra digits, then again you should be thinking of more associations. So the pre-axial and post-axial, classification, I didn't go into that. But if you have from the little finger side, that is okay. But if you have from this side, then maybe that's a pre-axial one, and then you should take care and search for other anomalies.
So for
Dr. Ashish.
Permission of Dr. Pankaj.
Yeah, yes.
I am Dr. Jalil from Coimbatore, Tamil Nadu. Excellent talk by Dr. Ashish. This is regarding the vaccine. The IAP has released the purple book. has given everything regarding all the vaccines and also the vaccines in a special situation where it is mentioned in the pre-term. And I'm happy that Dr. Ashish has mentioned about the extra two screening, like the stool chart and the jaundice chart. This has to be highlighted for all the practitioners. One more thing in the first exam, for examination, suppose we are seeing some pre-auricular tag, a dimple, as you mentioned, the Mongolian spot. Is it correct to mention these points to the parents and explain in detail? For example, they may go to the WhatsApp or Google the thing, pre-auricular tag. Many of the mothers, they are asking for the ultrasound. In that situation, is it mandatory or we will restrict or will bind our discussion to the parents in the ABCC concerns of the mothers?
Dr. Ashish, one more, I think 2 or 3 queries regarding the eye care. So, if the baby has got a eye discharge, then whether it is any the eye drop is recommended, and if not, then when it is to be given.
So I mentioned about the epiphora and the massaging. So many of these babies will have certain issues with the patency of the nasolacrimal duct, which is very transient. So in that case, he doesn't need any antibiotic eye drops. It is just the massaging. But if you find that these discharge is associated with congestion, that is the redness of the eye, then one should rule out infection, and it might be possible that the baby will need certain antibiotic drops. For the epiphora, which is common, you just have to massage in the anti-clockwise. So do that massage in the anti-clockwise whenever you're putting the baby, maybe 10 times or 3 times a day. And that generally takes care of the mucky eyes or the epiphora. But if there is a redness, if there is a swelling, then that indicates that there is some infection, and a gram stain and a octo consult along with antibiotic eye drops should be immediately started on these babies.
Okay. Any because the one question is there any your empirical antibiotic drop, or which eye drop would you like to suggest? Or if the gram staining facility is not available, or investigation is not available.
Okay, so we generally don't get much of gram negative because it depends on your environment. So we are not getting gram negative conjunctivitis. So we generally give moxifloxacin eye drops in a frequency or tobramycin. So these are the 2 eye drops which we generally give, but it changes depending on what gram stains we are getting.
Okay. So one more question regarding this is the bathing of the newborn. Some of the audience they want to.
Once you start the eye drops, there is also we have to stop them. So if you don't
Yes,
stop
of
them,
course.
you'll end up with chemical conjunctivitis and the vicious
Yeah,
cycle.
of course, of course.
So try
Yeah,
to sorry.
yes, of course. Once you start, but definitely the expert opinion has to be taken. Another question from audience, Dr. Ashish, that regarding the bathing of the newborn. The audience wants to know which soap is recommended, and is there any a specification for that?
Yeah. So when you're talking about the bathing, I said that we have to take care of the alkalinity of the skin. So let me tell you 2 soaps. One is the Rin. So Rin has a very high alkalinity and detergent effect. So it will have a very good cleaning and toileting effect, but it will be very bad on the skin. And on the other side, let me take a shaving cream. So the shaving cream has a very low alkalinity and it has a low toiletry effect. So what we intend in a baby is that it should not have alkalinity. So all the soaps which have low alkalinity, and sometimes they are added on by certain moisturizers, they can be used. So most of the baby soaps in the market, they play on this same simple rule that their alkalinity will be minimal. And as you go from Rin to the Dove to the Peer, so it's a spectrum where your alkalinity is coming down. So you can choose any soap. In fact, there are some. If you look at the evidence, it says that you don't need any soap only. So you also have preparations like no soap, which have no alkalinity or detergent at all. So they're just giving you a perception that you've cleaned the baby and putting some moisture onto the baby. More important than that is that you should follow the hydro oil method. So in the Indian context, many times we see that the babies are first oiled and then they are given bath. So that is against your skin care. First give the bath, so the water seeps into the skin, and then apply the oil so that it remains supple. So the sequence should be like we do for atopic dermatitis. So first give bath, after maybe 1 or 2 minutes you can apply the oil, and that would be better to maintain the moisture of the skin compared to oil and then bath.
Yeah, so let's just some of the questions which are beyond this. Cord cutting, is it necessary to use a blade or we can use it scissor also? Dr. Pradeep wants to answer. Ask.
Acha.
Scissor
So
or blade, anything is okay?
anything is okay, but it should be sterile.
Right.
That is the main thing, sterile and don't reuse. So initially we used to use the scissors, but now we find blades comfortable because we know that we throw them off after using once.
So if a newborn vomits any drug, any medication, suppose vitamin D, within how much time it should be repeated?
So, sir, again, if you look at the evidence for these things, generally it says that within half an hour, if a baby vomits, then you can repeat. But I am unaware that is there any scientific, literature giving that point of repetition.
I think common sense says that stomach capacity or the gastric emptying time is around 30 minutes to 45 minutes. So 30 minutes should be a good guide, especially if something is important, especially that happens with pediatric patients also. They vomit paracetamol and they say there's no effect. So within half an hour, it should be a good guide.
Yeah, so that's guide, but I have not looked at any literature.
Right. Vitamin K on left or right side, I think should not be a problem. Either side is okay.
Then mention it on which side you're given. That's more important.
Yeah, that's more important, right? And you can choose, see, left side vitamin K. See, you can, as a hospital, you can always choose that vitamin K left side and hepatitis B right side. So you can even ask the mother that injection dono side mein laga tha, ki left side mein laga tha, right side mein laga. That can be a good logistic way of knowing whether baby has received vitamin K or not. Pulse oximetry. Yeah. Dr. Alok, आपकी आवाज डिस्टर्ब कर रही थोड़ा. I think ABR you must have mentioned in context of the auditory brainstem response audiometry. So there is a question about a normal newborn or LBW is admitted in NICU for some reasons. What should be frequency of application of coconut oil? Coconut oil, massage or whatever you want to do. Frequency in a day.
So we are looking at, as I said, that the evidence is not great about massaging the babies, but then definitely application of coconut oil can be done. So they have been applied every 4 hours to twice a day. So even anything is okay. So maybe in a normal baby where we are not concerned with nutrition through the oil, even 2 times a day should be good enough. But that's my personal opinion. I don't know whether.
If you look at the evidence, those studies which have looked at weight gain, they have massaged 4 times in a day. And that's around 15 minutes coconut application. There are studies from India which have documented this, study from Nepal which did this. So in the study mode, you always do, rather you want to do it very often because you want to show an impact. So there it was done. So whenever we say baby gains weight, it's not that one massage in a day it will really gain weight, because ultimately it is not the oil which goes in the skin. It is the vagal tone which is stimulated, which makes the baby's heart rate low, BMR low, gastric emptying better. Any drug recommended for mother for low milk supply, like galactagogues? I am sure obstetricians are very, they use Dabur electronic granules as a routine for many mothers. Any recommended galactagogues, Dr. Ashish?
So if you look at the ABM protocols, for galactagogues, which are the Academy of Breast Milk protocols, so there would be some benefit of giving metclopramide to the mothers, but that should be given only in the earlier stages when the receptor levels are very high. But eventually, if you look at the confidence interval is quite wide, and it doesn't have a very strong effect on secretion of milk. So better is to look at the organic type of galactagogues like oil, fenugreeks. There you have a lot of preparations which have these as a constituents. So it works for some mother, it doesn't work for some mother. What is more important is take care of the psyche of the mother, the nutrition of the mother, and the water intake, and some evidence on the back massage which will increase the milk output. And most important is the night emptying of the breast. So I think these points are more important first rather than
Right.
correct.
Though I agree to that, Canadian guidelines about glucagon says that they recommend domperidone 10 milligram 3 times a day for a trial of 10 days to see whether it is good for newborns. Because Dr. Alok, please keep yourself on mute. Dr. Alok. So because the metoclopramide is known to lead to extrapyramidal side effects also. So domperidone is according to Canadian guidelines. I understand that Indian guidelines, they are mum on this issue. They are not recommending any galactagogues. But yes, there are some guidelines on this. Dr. Ashish, Dr. Pooja Sharma wants to ask, can pediatrician...
So you're freezed.
I think Dr. Pankaj lost the connection. Dr. Ravi, can you ask the questions?
Yeah, Dr. Ashish, one more question is
do weigh
regarding
themselves.
the...
And if they...
Yeah, Dr.
Hello?
Ashish. Hello.
Uh,
Yeah, Dr. Pankaj.
can you train people for doing OAE? Is it that pediatricians can be trained?
Yes, sir. They can be trained, and in fact, a healthcare provider can also be trained for OAE. And now you have these third-party integrations where the reports are, stored, so you can also review later as far as the quality is concerned. But like in our hospital, also mostly it is the healthcare provider and the 10th matric pass people who are actually doing OAE.
So, any recommendation that if baby is on antibiotics, you should delay vaccinations?
Not that I am aware of.
So we also not see if the baby is admitted in the NICU sick, then definitely we don't give at that time, but at the time of discharge. And we have made it now mandatory that all preterms also at 42 days, whether they're in NICU, they receive their quota of vaccination. So sickness, acute sickness, few days is fine, but should not be very delayed too long. There's a question by Ashish Sharma. Suctioning is not recommended normally, but 90% of normal newborns always have copious oral secretions and gentle suctioning help. Is there any harm of getting suctioning? Very relevant question. Yeah.
So I would slightly, disagree with the, Dr. Saab that 90% of the newborns, they have copious secretions. So unlikely. So we have to see why like that it's happening with him. But then obviously, if there are secretions which are affecting the breathing of a baby, so that's very important. If the baby is born and there are some secretions which are not affecting the breathing of the baby, then I think a simple clean by gauze piece is better, because that doesn't nip off your mucosa and it doesn't create a negative pressure to the mucosa. So maybe I would summarize this way, that if there are secretions and the baby, you are having problem with, initiating the breathing, then you can clear them. But if the baby is breathing normally and there are some secretions, then just take a gauze piece and clean them off. Don't use the suction.
Dr. Surinder Bisht will be taking session on NRP next Sunday, so he can be also important guide in answering that question. But what we do in our setup is that if baby does not require any positive pressure ventilation, it does not require suctioning also. Exactly. So he's breathing fine, there's no need. Dr. Rashi wants to ask that if there is only yellow discharge at the inner canthus, but no redness, do they still need antibiotics for eye care?
No, that is how the epiphora presents. It presents as yellow discharge of the mucky eyes in the inner canthus. So that is mostly epiphora. If there's no redness, first try to do eye massage and cleaning of the eyes, and then re-examine the baby after 2 days.
So, doctor wants to ask that if iron normally causes constipation, so can it be restricted to only less privileged family where nutrition is poor, or it should recommend routinely to all at 6 months?
Deciding that, the less privileged, because if you look at the iron deplete mothers also, their babies are not deplete unless they are born early. So one thing we should understand, that even in spite of maternal anemia, which may even a hemoglobin of 8 is good enough for a baby to lynch out iron which is required for him. So if a baby is born at term, then maybe you should, and you think that the iron is causing a problem, then try to focus on good complementary feeding. As I said, that if the complementary feeding is good, then iron in supplementation may not be needed also. So try to focus on homemade preparations. There are a lot of nutrition Institute of India guidelines on complementary foods for different communities. So those can be discussed and they will be good enough to take care of iron in these
I
babies.
think iron utensils, if you start cooking our food in iron utensils from the childhood itself, maybe they develop taste and then the family also is benefited because everybody starts eating that food. Please guide regarding nail care. I think many parents ask how to clip the nails. Is there any particular thing you want to say, Dr. Ashish?
So I think if you look at the literature, the focus is more on time of clipping. So the time should be after they had a bath so that the instrument is soft. And there are some now a lot of baby nail clippers. So you can use them. But then again, why we want to clip, that's important. So if this nail is, causing certain excoriations and they are abnormally grown or abnormally curled, so that is a time when you should try to clip, but routine clipping of nails is not required.
Right. So, Dr. Rupanjali want to ask, when do you start iron supplementation in preterm babies? Though there is a session separately for that, but yes, it all depends that full-term babies, we don't want to start at 6 months. We want to start at 6 months.
So as I said that, categorically we categorize into three: VLBW, LBW and ABW. I showed you the chart of ABW and LBW. So in VLBW babies, we start at 15 days. That is 2 weeks postnatal of life. We start with iron. And also the doses may be slightly more there, preventive doses.
So what should be the frequency of eye drop usage? How many times in a day?
So eye drop, for antibiotic eye drops?
Antibiotic eye drops.
Infection. Okay. So if there's an infection, generally we start at around 8 hourly, instillation, but then it depends on response. A lot of times we take help from our ophthalmology colleagues who would even tell a frequency of every 4 hours if the infection is severe. But I think 3 times a day would be good enough for 3 days in most of the infections.
Can you investigate?
Dr. Ashish,
Yeah, Dr. Ravi, just after this question, you can take over. How to investigate a colic? How are you sure that it is a colic which is bothering the baby?
So to be very frank, we don't face much of colics in our hospital. I think you can take the question that what you do. But if I look at the literature of colic, then I think Lactobacillus reiteri is only one which has a meta-analysis which says that there's some benefit. But as far as investigation of colic is there, then first you have to identify whether this cry is colic cry, pain cry, or associated with certain other symptoms. For example, if there is a anal fissure, if there is a umbilical redness, so these are the things when you will try to do a screen on a baby whether he has sepsis or not. Otherwise, if the pattern is very classical, it generally doesn't warrant investigation. That's my take on it, but I would like to.
I think colic babies normally they are growing babies. They are gaining a lot of weight. They are passing a lot of flatus. They are better on their tummy, so tummy time. Or if you rock them, they are better. As soon as they lie down on the bed, they start crying. And what I tell my patients is the car test. So if you, I'm sure most of the patients who come to us, they have cars. So if you baby comes in a car to your clinic and sleeps on the way, it is always a colic because rocking or moving of the baby always makes it quiet. On the other hand, if something is really bothering the baby, like otitis media, like fracture, like cellulitis, rocking may be actually more deleterious. It may be more disturbing to the baby because you're touching the abnormal area. So that can be a good clinical point, but as such, there is no investigation for this. And I'm sure if the baby is growing well, then you are reassured that there's nothing great to worry. Over to you, Dr. Ravi.
Yeah, thank you, Dr. Ashish, for such a patience, answering the query. So I think most of the queries has been already sorted out, and I think we would like to take two questions. One is regarding the stool pattern. The most of the baby you might have observed that their baby is not passing his stool for 3 or 4, 5 days, or even maybe beyond. So some of the audience there are a few questions regarding this. If the baby is not passing his stool for how long, and if then when to intervene?
Yeah, again, so it is an association which you look at. So if there's no distension, then the stools may be passed even at 72 hours. So they may also be not passing stool for almost 3 days and may pass up to 8 times in one day. But if that non-passage of stools is associated with vomiting associated with distension, then it's a matter of concern or an abnormal
So even
position
if
of
they have specifically asked about if the baby is not passing since 8 days of not pass the stool for 8 days, and still there is no discomfort. So for how long the parent should wait?
I think one should look into the feeding of a baby, because if the baby is not feeding well, or maybe he may delay the passage of stools. But then physiologically, if the stools are getting delayed, then I think one should also investigate for hypothyroidism and hypocalcemia. So these issues are there which may actually delay the passage of stools.
Okay, if the baby is not passing for too long, then definitely the cause has to be, investigated. So
Yes.
one more question is regarding, the shape of the baby. Most of the parents, they are very concerned about the shape of the head, you know. So is there any recommendation to, because it has got some cosmetic, appearance with especially for the female child. So is there any recommendation to, for the, the head support, or just to have a good head shape?
I think what is mentioning about is the positional plagiocephaly. So if you put a baby at one particular position, so there may be some flattening on that side. So the best thing is to rotate the direction of your bed, because it generally happens that if the ball is there on one side of the bed, so the baby is always looking at the side when you're moving around. So try to change the position of the baby when you keep him on the bed, so that he's given an opportunity to look at all places. So that's a simple way of preventing positional plagiocephaly.
Okay, so we can change the position of the baby while on the bed.
Yes.
Okay, thank you so much, Dr. Ashish, and I think over to organizers again.
No, I think
Dr.
there are
Pankaj.
certain more questions. We have promised that all questions will be answered, so I have to keep my promise. Certain routine things. I think there are certain pediatricians who are in routine passage of esophageal for patency, the feeding tube, and for routine anal opening probing by the suction catheter, or by routine stomach wash. What is your comment on these three routine practices which many of my friends do?
So, sir, the number needed to treat for these particular interventions is very high. So they may go more than 500, 600. Meaning that if you want to detect one, abnormality in the patency, you will have to do this for almost 500 to 600 babies. So which is really harmful for certain babies. And then it is seen that uh, these things are not missed. So even if you don't do it, maybe within 24 hours, the baby will show you some signs that he has certain problem. So we have not now stopped doing this routine suction and routine passage of tubes into the anus to look at the patency.
But you should look at the anal patency. So
Yeah,
at
that
the
is there.
same time,
That definitely is there. I'm talking about
yeah,
inserting.
we don't probe, because there's a question that any medical legal implication, and I know there's a case
The
which
location and the presence of the anus should be
has to
written.
be
Then
documented.
then there will not be any medical evaluation.
Right. So Dr. Murli Krishnan wants to ask, is it better to give multivitamin rather than vitamin D to the baby, because maybe mother is having some other new micronutrient deficiency which can be taken care of? Right now, we only recommend vitamin D to normal newborns.
Yeah.
Any point in using multivitamin drops to the babies?
Okay, I thought you answered that.
No, I've not answered, because they said that let us give vitamin D to all babies, because we are saying vitamin D, but he wants to say use multivitamin drops.
So I think the multivitamin drops, the multivitamin RDAs are taken care by breast milk very nicely. So what was found deficient in the breast milk grossly was vitamin D. So I think the multivitamin should not be given to the babies routinely. So you can just give vitamin D, and maybe, as I said, if the baby has low birth weight, you can add on iron, but nothing more than this.
And we don't want to wait for G6PD report for vitamin K. Vitamin K in that dose can be given before even waiting for the G6PD deficiency report. Any comment on vitamin K2 in place of vitamin K1?
So a lot of studies telling some increase in kernicterus. We were giving vitamin K for a long time, and we didn't see that. But now, as vitamin K1 are available, very nicely in India, I think we should go by science and avoid giving vitamin K2.
And if you're not sure whether baby has received vitamin K or not, can you repeat this without any harm?
Yes, you can repeat the same dose without any harm. It's
Right.
always better to repeat rather than give send him without giving vitamin K.
So vitamin D, lipid soluble, water soluble. Any difference in the two?
Vitamin K or D?
Vitamin D. Vitamin D oral. There is a nano preparation which is water soluble. There's a lipid preparation. Cost is different.
You are expert for vitamin D, sir. I don't know.
So water soluble is that you can give it any time, irrespective of the time of breastfeeding. But what fat soluble vitamin D have to be given immediately after breast milk has been given, because otherwise it will not be absorbed. Otherwise, there are certain studies which show that the water soluble is better because it is better absorbed. But as far as recommendation is concerned, you can give any one of them if you take care of this precaution, that if you give after fatty meal, which breast milk is, then everything is okay. If you want to use it empty stomach, then maybe water soluble will be better. Okay. Rows of probiotics in neonatal jaundice. I think this session on neonatal jaundice will discuss jaundice and probiotic there. But as such, I don't understand there's any role as of today. Intervention for redness around the cord area. I understand omphalitis is different, but there's sometimes this little bit of redness around the umbilical cord. Anything needs to be done for that?
So if there's a little bit of redness around the base of the cord, which is very near to the base, and there's no induration there, and the baby is not, showing you any symptoms of like fever, pain, excessive crying, I think that should be left alone. And but important is observe for any progress, and if observe for any progress, then it should be akin to umbilical sepsis. So many times we find this, that there's a small ring of redness around the umbilicus, but it doesn't progress, and it's a part of sterile inflammation which is occurring before the cord is falling. But if this redness extends in diameter, or there is an induration, or when you touch that the baby winces, so then definitely there's umbilical sepsis.
So there's a separate session on newborn screening, but somebody wants to ask, can you use cord blood for hypothyroidism?
You can use cord blood for hypothyroidism, but then there are different criteria to interpret it, because there will be a surge of TSH which is high soon after birth. So the only thing is the interpretation becomes difficult, different. But then if you're doing other screening along with the thyroid, then they all have to be done at 48 hours to 72 hours. So better is that this can be clubbed with those screenings.
Any comment about Besan or Uktan, which is done in some communities while bathing is still recommended?
I don't know, sir, what is that?
Right. Besan, people apply Besan so that the hair go off faster. So I don't think so it is recommended. I have seen babies getting skin excoriation because of that. So there's an interesting question. After umbilicus is fallen, parents come with complaint of watery discharge from the cord, no redness, no periumbilical skin. They still ask for medication. Any recommendation? Only watery discharge, little bit from the stump.
Yeah, as I said, that's a sterile inflammation which is going on, and we don't need anything. But then we should always think of the vital intestinal duct which may be present at times. So if this is increasing over time, or if you do a churning movement and you see that the secretion rapidly increases, I mean, there you have to do a sinogram and rule out urachus or vital intestinal duct. But if you are just churning and there's no increase in secretion and it is decreasing over time without any bulging redness in the umbilicus, so that also the mucosal findings in the umbilicus, I think that's all related to a sterile inflammation, and to take care.
A fully formula fed baby, does it still require vitamin D?
The formulas, I think, have around 230, maybe 200, and the term formula has around 230 IU of vitamin D as a total requirement. I think that should be good enough. So
I think the recommendation is that if the baby is consuming 1 liter of formula, then vitamin D is not required. So it contains closer to 40 or to 40 unit per 100 ml. So normally we are not, I give it to all babies, because usually you are always saying that breastfeeding is recommended. They are taking some amount of breast milk. Usually they are not taking around more than 700, 750 ml of, and the upper limit of vitamin D intake in any case is 1000 IU per day. So in my practice, I don't say that formula fed don't give vitamin D, breastfed give vitamin D. We give it to all babies, and the recommendation is 1 liter of formula. Colimex drops, do you recommend for colic?
So I think, as far as I know, so we're not using that. Again, we don't have experience, but the Colimex has methocaine, and they
Dicyclomin
are now
bromide.
Colimex also without that and just phenyl and this. So the dimethylmethacrone
Cyclomin.
is not recommended for colic. As I said that if you look at the meta-analysis, it's only the lactobacillus reuteri which has shown certain benefit. I think it comes by the name of Proctus or I don't know what. So that people are trying, but otherwise it should be avoided as a sedation to the intestine. It should be avoided.
Simethicone drops can be used, but hyoscine bromide or dicyclomin, they are anticholinergics. They can increase the temperature of the baby, and the baby may become more warmer. And it is not recommended less than 6 months of age, which is the age of colic. So we don't recommend Colimex drops. Any age of starting massage? Can you start on day 1 or you have to wait for a few days?
Yeah, you can start on day 1 also, sir. There's nothing because it's a form of touch therapy. So one can start, but then you should be careful that again, as I said, it should be a application, but not a rigorous massage, especially in LBW babies.
Any comment on calamine lotion for skin rash, whether they interfere with the phototherapy?
So is that applied all over the baby?
Yeah, I don't know, but calamine lotion we don't recommend as such because calamine lotion is for itching, and as I'm told that newborns they hardly itch because their skin does not have that type of chemical histamine release and all. So I don't recommend calamine lotion at all. Uh, in I think breastfeeding, there are a lot of issues on breastfeeding. Whether we can have a session on this. Eye conjunctivitis has been a very favorite topic, so everybody has been asking, but we have answered this question about bathing also. Uh, I think the list is endless. There are more than 100 questions. Dr. Ashish, your lecture has been super successful in generating a lot of.
And Pankaj, I'll just share with you a happy news that we have HSD of Central IAP, Dr. Yogesh Parekh, also with us. He was also listening to your interaction on very wise questions.
Yeah.
Namaskar, Dr. Yogesh ji.
Namaskar and good morning to all Pankaj ji and
Good morning,
Ashish and
sir. Good
everyone.
morning.
We are listening your this question answer session. Just now I am joined with Dr. Alok Bhandari, and it was wonderful session. You are and they created this platform for the digital learning to the participants. So please carry on. Best wishes for the
Thank you.
future
Thank
programs.
you so much for
Thank
gracing
you.
our
Thank you.
presence, sir. It's very
Good
Yeah.
morning,
admirable
Yogesh ji,
that you are
sir.
with
Good
us.
morning, Yogesh ji.
Yeah. Jalil Saab, thank you very much.
Right,
Nice to
right.
see all of you.
Thank you, Dr.
Thank
Yogesh.
thank
And
you. Thank
before
you.
we
Thank you.
close,
Thank you.
Dr. Ashish, two more umbilical granuloma. You want to do something about it, or you want to wait for some time before you treat?
So the umbilical granuloma, obviously there are two ways you can handle it. In fact, three ways. One, you can do a salt sprinkling on the umbilical granuloma, and there's a whole lot of protocol how you do that, and it has emerged from one of our Indian hospitals only. So you sprinkle the salt and then cover it with a gauze piece, keep it for 20 minutes, and then clean it. So do this for around 3 times a day, and generally it resolves in around 5 to 7 days. The second option is to go for silver nitrate, which you generally don't do because if you're not limited to the granuloma, then you may also cause, some necrosis of the skin. And if it doesn't respond to generally the salt in 7 days, then you can do a simple ligation and remove it. But then again, you should understand that sometimes the granuloma, the vital intestinal duct and the urachus will mimic the granuloma, very closely. So try to again, as I said, try to massage the umbilicus and see if the secretions are coming out. If they are coming out, then that thing should not be subjected to all these interventions because one, we have to rule out the vital intestinal duct or urachus there.
Right. Thank you. How to manage
Dr.
prenatal
Dr.
tooth?
Sorry, sir.
Prenatal tooth. Babies are born with some tooth which are not loose or loose.
Yeah.
How do you manage them?
So they are generally the supernumerary tooth, and at our place generally we remove them because our follow-up rates are very less. So, but then if they are not dangling and they are just mucosal still, one can carry on. But most of the times we end up removing the unit tooth.
Right. So we don't recommend pacifiers as a country, as a community, though we understand that American Academy recommend pacifiers to reduce the risk of SIDS. SIDS somehow is not common in our country, and pacifier can interfere with breastfeeding. So we are not recommending that. We also don't recommend suppository, even if baby is not past stools for 4 to 5 days, because we know it's no harm done. Right.
Dr. Ashish, one doubt from me. If the newborn comes to the ear discharge, what do you advise? Ear discharge.
Ear
Sometimes we get.
discharge.
Yeah, sir. So that really is serious. I mean, it should not be taken lightly if a newborn has come with ear discharge. I think he needs a eardrum examination and then examination of the external auditory canal to see if there's any problem there. So because we are not very well, versed with the ear examinations, I think it's better to take a otolaryngologist opinion on this rather than end up starting antibiotics and then referring after some time. Once there is no perforation, then obviously it's the ASOM treatment which is there. We can give one of the antibiotics, but it's always good to look at the eardrum before you mount on managing this baby.
So cord blood banking we will be discussing in the next lecture, because we have a lecture on NRP. Cord blood banking will be discussed there. There's nothing like meconium-induced gastritis, which is a misnomer. We should stop using that term. Meconium is an innocuous substance, does not cause gastritis. Blood sugar, we want to monitor if a baby is asymptomatic, born to high-risk factors, or if baby is lethargy. Definitely, we should be doing blood sugars. Colleague, we discussed salt therapy in granuloma. Dr. Ashish very clearly mentioned that salt therapy can be used in umbilical granuloma. Does breastfeeding in lying down position? Do you recommend lying down position breastfeeding?
Yeah, so any breastfeeding where the mother is comfortable can be done. So there is no harm that the mother can feed in lying position. So there's no contraindication to breastfeeding in lying position.
Right. So, Dr. Ashish, there were 118 questions which were posted in response to your talk. That tells that how much interest you were able to generate in these 400 plus delegates which attended today's session. And I'm sure the group is open, and faculty is also there, and we are also there. So if any of the delegates of this eNeo certificate course wants to ask questions, is still free to ask questions in the group. I have tried my level best to take all the questions which came into the question and answer session, and I've been helped by Dr. Ravi Sachan, Dr. Alok Bhandari, and others in this endeavor. But if any last comment you want to make, Dr. Ravi, before we hand it over to Dr. Ashish and then to the organizer?
I think I second your, your thought that such a engagement, such a huge engagement of question, that it's itself explanatory for the, the popularity of the program, and the very, I think I congratulate Dr. Ashish for such a patient, answering each and every question so comprehensively. So that's, tells about the Dr. Ashish. Thank you so much, and everybody, and I think. Not to take much over time, over to Dr. Alok Bhandari and other organizers.
So thank you so much. Dr. Alok said he'll be busy, though he's visible on the panel list. If he's there, Dr. Alok, you want to say a final word? Yeah. Dr. Alok? Yeah, I think it seems to be busy. Thank you, Dr. Ajil Ahmed. Thank you, Dr. Lalit, Dr. Vipul, Dr. Ravi, who are still on the platform. And most important thanks goes to Dr. Ashish Jain. He has been very, very patient in answering all the questions. I understand these questions are those which we have to answer on day-to-day basis to the mothers, to the residents, to other colleagues who ask these questions, but they are important. As we always say, question is the most important basis of science. If scientists don't ask questions, they will never get the answers. So keep on asking questions and keep on searching for intelligent answers. And I'm sure by the end of it, the newborn care in the country is going to improve further. So thank you so much. Thank you, everybody. I think Dr. Vipul, if you're there, Dr. Alok, if you're there, last word from you. Otherwise, from my side, it is done. Thank you.
Thank you, Dr. Pankaj, Dr. Ashish. Wonderful session. And see you all delegates next week, 9 a.m. on the same platform with another topic. And we're going to have similar topics for several coming weeks, every Sunday. Thank you, Dr. Ashish. Thank you, Dr. Jalil, for being there and supporting us. And see you next week. Bye.
Next session
Thank
is
you, sir.
by Dr.
Thank you, sir.
Surinder based on neonatal resuscitation. So be there next Sunday, 9 o'clock.